Hello, I'm Dr. Marla Shapiro. I'm a past president of the North American Menopause Society, and I'm joined today by Dr. Pelin Batur to talk to us about contraception. She did her internal medicine residency and women's health subspecialty fellowship at the Cleveland Clinic. She has been practicing since 1998, and her range of expertise includes medically complex contraception, menopausal care, menstrual migraine, and really what we want to talk about today is contraception. And we particularly want to talk about contraception in women in that stage of life where we call it perimenopausal. So first, let's start off for our women who are listening. What do we mean by the perimenopausal period of time?
Yeah, perimenopause is the years that occur, or the changes in your menses. Sometimes you have symptoms, and these are the years leading up to menopause. And menopause is defined as a full 12 months without periods, but in the absence of any type of medication or medical conditions that may contribute to the absence of periods. And the perimenopausal time period can be actually a difficult one with up and down of the hormones causing both symptoms of menopause as well as irregular bleeding.
So if I'm in my late 40s, early 50s, and this is happening to me, isn't it unlikely that I'll get pregnant? Do I really need to think about contraception?
Well, yeah, unfortunately, we still have to think about contraception until we are fully in menopause. Um, if you look at rates of unintended pregnancy, surprisingly, for women who are in their 40s, it's just as almost as high as other age groups, even adolescents. And, even though younger age groups, if they have an unintended pregnancy, they may have a higher chance of having a live birth. That's the main difference. But still, it can be quite a shock if you're not ready either emotionally, financially, or physically to have another child or another pregnancy.
Okay, so we need to be thinking about this. I guess the key is if you're not yet 1 year into a full definition of menopause and you're sexually active, then you do have to be aware that a pregnancy could happen. So, what are my options during the perimenopause in terms of what's safe and what's out there for me to use?
Yeah, we still have the full gamut of options that we have when we are in our, teens or in our 20s or 30s, but we have to think about the risks of sometimes the estrogen containing products. So it's really not it's not the age, but it's the medical history that defines whether a woman is appropriate for a contraceptive method. So the vast majority of women can still use non-hormonal methods. Condoms are not as effective as people think they are. Anywhere from 15 to 20 out of 100 women using that as their main method can have an unintended pregnancy at the end of a year. Now, that being said, if you're in your 40s, nearing your 50s, it's probably more effective than that. But that's just something to consider. If really preventing a pregnancy is high on your priority list, sticking to just condoms is probably not the best non-hormonal choice. The vast majority of women can also use progestin-containing contraceptives. So our hormonal contraceptives have estrogen and progestin, or just progestin. And there are very few women who can't tolerate a progestin-containing contraceptive. Perhaps if you are recently being diagnosed and treated for breast cancer, that would be a reason to think twice about that. Or if you're on certain medications, seizure medications that can impact the body's ability to handle the progestin, where you have lesser doses of the contraceptive. So there are some exceptions of women who can't use a progestin-containing contraceptive, but the vast majority of women can. What works best for perimenopausal symptoms are the estrogen-containing contraceptives, and that's where we have to weigh a little bit more the risks and the benefits, because the estrogen impacts risk for blood clots both in the arteries and in the veins.
So, if I'm in my perimenopausal years and I've got sort of the double whammy of menstrual irregularities, now I need to be concerned about pregnancy and I'm still having intermittent hot flashes, how
Mhm.
is that going to guide you to help me to choose something that maybe will put a band-aid over many of these symptoms and keep me contraceptively protected?
Right. So if a woman is having a lot of symptoms, typically an estrogen-containing contraceptive is going to do the best job controlling those symptoms. So what are some of the symptoms that women worry about? Like the ones you mentioned, the abnormal bleeding, the hot flashes, but also disrupted sleep from those hot flashes or night sweats, worsening of acne, hair loss, hair where you don't want it, hormonal headaches that sometimes can get worse during the menopause transition. In addition to the abnormal bleeding. So these are all conditions that really can impact quality of life, where an estrogen-containing contraceptive can really bring the quality of life back on track. So there might be sometimes more of these medical needs as well, beyond just the birth control needs.
So let's just talk a little bit about risk and the age of women in perimenopause looking at contraceptive options. Are these risks higher, and really what should we be focusing on?
Right. So if a woman is terribly high risk, we can always start with a progestin-containing product to see if it helps, because sometimes they do help these symptoms, especially the bleeding. Sometimes it can help with some hot flashes. But if she's really not doing well, then we do have to talk about estrogen-containing options. And it turns out if we stick to lower doses, we do minimize these risks. And luckily, many women in their 40s can get great control of their symptoms with lower, ultra-low doses of contraceptive dose estrogen. Um, Things to factor into the discussion, risk factors for what you would think for heart attacks, for example, uncontrolled blood pressure, diabetes, especially if there's complications or multiple risk factors for cardiac events, then I'm going to either stick to ultra low doses or steer her towards a progestin option. Now, the one other nice option we have is women can use a progestin IUD that helps control her cycles, but then we can just use tiny postmenopausal doses of hormones to help guide her with her symptoms. And that way, the lower we go with the estrogen, the lower we reduce her risks. And the one other thing to factor in is being overweight or obese, because that does increase your risk of also blood clots. It certainly does not preclude the use of estrogen-containing contraceptives. We do try to steer all women to the healthiest lifestyle possible, but if a woman is otherwise healthy, even if she's overweight or obese, she can use estrogen-containing contraceptives. But you can't smoke if you're over 35 and you want to use estrogen.
So before I let you go, for our women who are in their 40s, in their 50s, struggling with perimenopause, now knowing that they need to think about contraception, any other take-home points for them to tuck away?
Yeah, so the big thing to take away from any discussion on contraception is that the risks of an unintended pregnancy are always greater than the risks of contraceptives. We know so much about these methods. We've been, using them, studying them for 50, 60 years. So we talk about lots of little risk of this and a little risk of that, but unintended pregnancy is a big stress on the physically on the woman's body, and so that is something to keep in mind. That if you know I always have that conversation. Is pregnancy in this time period of your life, would it be a blessing, or would it really throw a curveball in your life? And if it is, that it's going to impact um, both health to her or to her fetus, then we really have to think about the contraceptive, knowing those risks are lower.
Thanks so much for joining us today.
Thank you so much. Take care.
Bye for now.
Bye-bye.